Evening. Thanks for joining us. The topic today for this webinar is novel therapeutics, approaches to improve outcomes for patients with PAH. So first I want to welcome my colleague and good friend, Aaron Waxman. He's the Director of Pulmonary Vascular Disease Program, the Executive Director for the Center for Pulmonary Heart Diseases at Brigham and Women's up at Harvard. For those of you who don't know me, my name is Marty Gomberg-Maitland. I'm the Chief Research Officer at GW Office of Clinical Research and Director of the Pulmonary Hypertension Program at George Washington University. The learning objectives for this evening is to, one, describe the challenges associated with diagnosing and treating patients with pulmonary arterial hypertension, including talking about common comorbidities and concomitant drug therapies, because this has really been what we've been facing now in clinical practice. Two, to evaluate the clinical trial data, safety, and efficacy of emerging therapeutics for the management of pulmonary arterial hypertension. And three, to identify strategies to effectively identify adverse events, optimize therapy, and improve outcomes for patients with pulmonary arterial hypertension. Let's start right from the beginning, which is, which of the following is not part of the diagnostic definition of precapillary pulmonary hypertension? Choice A is a mean PA pressure greater than 20. Choice B, mean PA pressure less than or equal to 15 millimeters of mercury. Choice C, a right atrial pressure greater than 10. And choice D, I don't know. So, I think it's important to point out that the definition of pulmonary hypertension is a hemodynamic definition. It's not based on any of our imaging modalities. And then, Aaron, the definition seems to keep changing for better or for worse based on the more data we obtain. But I think this is all good.
Yeah, I think importantly about the changing data, just past 2 weeks, the new updated guidelines were released, and the mean PA pressure being greater than 20, the wedge less than 15. And importantly, they lowered the pulmonary vascular resistance to what I think many of us thought was appropriate, a PVR of 2 Wood units being the upper limit of normal. And it looks like most people got it right, hitting the right atrial pressure as not being part of the definition of precapillary pulmonary hypertension, which is exactly right.
Correct.
And
okay, good.
Answer of I don't know also was up there. But
okay. I think that the thing that's changed is the mean PA pressure greater than 20. We had set it at 25 back at the World Symposium. Now it's 30 years back plus. And we've changed it because of the data that we have on the normal distribution of mean PA pressure in healthy individuals. And we've actually correlated pathology to the slight change in the mean PA pressure, meaning worse outcomes when the mean PA is greater than 20. So how is it defined? So as I just stated, the pH for precapillary, it's a mean greater than 20. And for all of our definitions now, irrespective of the actual grouping of the pulmonary hypertension, which category it is, the mean is 20. For precapillary, it's less than or equal to 15 for the wedge. And the PVR has now, based on the European guidelines, dropped to greater than 2. And that's a whole another debate, but it previously was greater than 3. And really what we're looking is for vascular injury and vascular health, and we just want to get patients treated appropriately. The isolated pulmonary capillary pH, which is really just backward flow without vasculopathy, is a wedge greater than 15 with a PVR less than or equal to 2. And then combined pulmonary hypertension, when it's left heart disease, is both vascular, so arterial, and venule hypertension. So the mean PA is greater than 20 the wedge is greater than 15 and the resistance is greater than 2. And then the European guidelines added this exercise pH, which goes in and out depending on what year we're looking at this. I think that later Dr. Waxman's going to tell us, how important it is sometimes to actually demonstrate the pressures with exercise, right? All of our heart caths are at rest, and some people clearly have an abnormal response of their pulmonary vasculature with exercise. The definition that they set was a mean PA pressure over the cardiac output slope between rest and exercise of greater than 3 millimeters of mercury. So I think it's really important that you realize that it's a restricted blood flow through the circulation, resulting in the increased resistance, which causes workload on the right ventricle and ultimately right heart failure is how these patients pass. The diagnosis, no matter how well we've been out there teaching for years now, we still see patients late in the disease. And that's because the signs and symptoms are often nonspecific of just shortness of breath, exertional shortness of breath. Sometimes people think they're just getting older. The things that are concerning are a pre-syncope or lightheadedness with exercise or actual frank syncope, because this means that the pressure is high and it's a fixed obstruction. And when you go to do something, you can't raise your heart rate and your blood pressure goes up, and then you have a fixed obstruction. And chest pain is RV ischemia. What is over on the right side of the screen really is just telling you the whole workup of what we're trying to do, which is to make sure that we don't miss something else. And this, I think, will become an area of debate as to what testing is the most important. Clearly, a good history and physical exam. You want to rule out lung disease. You want to rule out clots. You want to make sure that they don't have or know if they have concomitant connective tissue disease. You're really trying to look towards the etiology of what this could be, and then ultimately a right heart catheterization. Again, you can see when patients don't feel well, they often have just nonspecific symptoms. And I do like this new picture from the guidelines that just came out, which basically says to you, try to identify a cause, see if there are signs of low output or low flow, forward flow, which is in the bottom right-hand corner. So these patients can be now cyanotic and hypoxic from the VQ mismatch versus signs of backward flow when the RV pressure is high and the PA pressure is high, and you get signs of right heart failure, which is edema, ascites, etc. So, it's a nice way of looking at it instead of just here are all the symptoms and this is what you need to look for. So, as I stated, we are really not great at diagnosing pulmonary hypertension early in the disease. And that's because patients present to us when they have limitations in what they can do. The few that I've had that have presented early have been familial, or they were at high altitude or some other stress that brought out the fact that they were dyspneic that they hadn't been before. So what you can see is that patients often get misdiagnosed with PH, and they really actually either they're misdiagnosed with one of the other causes. They think, oh, it's just the COPD, or it's their asthma, or they're obese, or they have left heart disease, but could have PAH, and then vice versa. And there were multiple studies now. We did one over a decade ago, which showed that patients don't get the whole workup, and we often treat inappropriately for the wrong group of pulmonary vascular disease. So it's a kind of a cute slide showing the journey of the diagnosis and where we go wrong and why it takes so long. And that's because multiple doctors will see the patient. If you have a relatively young, healthy patient, or even somebody in their 40s and 50s, which is still relatively young, and I can say that at this point, and they didn't have any issues and they think they're just getting out of shape. So the primary care doc, kind of says, yeah, you're okay. And then they have some palpitations. Maybe they're anxious. You'll get an EKG, hopefully, which may or may not show RV strain. Sometimes it's kind of looked at and they go down a route of coronary disease. Eventually, and you see it's at this 1 year time period, and they're not getting any better, they start getting hospitalized. And when they get hospitalized, that's when a lot of the workup gets done. This was from ERS presentation, and it's not every center, but it just kind of shows you that everybody touches the medical system at different points, but a lot of times we're seeing it in the hospital. Once we know that you have true group 1 pulmonary arterial hypertension, we want to be aggressive and we want patients to feel better and be able to go back to their normal routine. And if they didn't have a normal routine because they were so impaired, we want to get them to a normal routine. And what's happened over time is we've had different goal-oriented approaches. And now what we're striving for is to get the patient at the lowest risk profile, which means a very low risk of death at a year. And this is the goal. And in order to do that, pulmonary hypertension is high pressure in the lungs. We want to improve hemodynamics. We want to improve right heart function. We want to avoid hospitalization. We want to hopefully reverse remodel the RV and get the function back. And hey, wouldn't it be great if we had a normal exercise capacity? We slept better and we had better quality of life. And hey, these patients, we all know, the folks that have been taking care of them for a long time, is that these patients now are living a relatively long life compared to when it was just a fatal disease and we didn't have any therapeutics. So this slide is now almost a decade old. It's the REVEAL data when it first came out, and we matched it to the NIH cohort. So for those of you who don't know, the NIH cohort was the first group of patients looked at with what used to be called primary pulmonary hypertension, which is now idiopathic and hereditary and anorexigen PH. So these were young patients, and we didn't have any therapies other than the vasodilators that they were using at the time and warfarin, and their survival. And what you see is the 5-year survival rate was 35.8%. So this was like a cancer, and there was no cure. And with REVEAL and with all of our registries, really now the 1-year survival has been over 90%. Which is a big change. And that was with just a few therapies that were available at the time of the REVEAL registry. So we want to catch them early, and we are doing a better job, is kind of what I would say from this take home from the slide. How do our current therapies work? And this is a slide, I like the way that we've done this to break it down, because I find that when we show a lot too much, then it just gets lost. So there are 3 pathways that our current therapeutics target. The first is the endothelin pathway on the slide. It was not the first therapeutic that was approved, which we will get to, but it was the next one. So endothelin is an endogenous vasoconstrictor. If you think about snake bites and why they are so poisonous, it's because it gets to exactly where it needs to go. And the first one that was approved was bosentan. We now have more selective ambrisentan and macitentan. What you can see on this slide as it starts to grow out and build out is it's not a sort of miscommunication, interaction between the endothelial cells and the smooth muscle cells, where instead of getting vasodilatory properties, we get a vasoconstriction, and what ends up happening with the smooth muscle cell is we get an inflammatory process. The second is the nitric oxide pathway, which you can see here on this slide. The therapeutics, most of us knew it from other indications. So sildenafil and tadalafil are PDE5 inhibitors. Great news, it's not just for erectile dysfunction, that we have lots of receptors in the lungs, and we've done a good job with vasodilating with these therapeutics. Then came riociguat, which is a guanylate cyclase stimulator. also a nice vasodilatory drug that has shown effects both in PAH and CTEPH. My bad. And then finally, we have the prostacyclin pathway. So our first approved therapeutic was intravenous epoprostenol. It's the one therapy that's shown improved survival, because now we're doing so well with all of our medications, we probably, until we cure it, will be hard to show survival benefit. But I think all of us know that these patients are doing much better. There's also iloprost and treprostinil. Treprostinil comes in all three forms: oral, inhaled, and IV sub-Q. The other two, iloprost is inhaled. You can get it in Europe as intravenous, and epoprostenol is just in the intravenous form. We have agents that work sort of indirectly through these pathways now. So Lexapeg is a prostacyclin receptor agonist, and we're working on new pathways. And so what I think we've done really well is try to target this vascular dysfunction with vasodilatory drugs. And all of these drugs have anti-proliferative effects, but the predominant effects have been vasodilatory. Unfortunately, we can't biopsy these folks, so we're not sure exactly how much sort of vascular change we've been making, but patients are clearly doing better with our current therapeutics. So this is the new algorithm, and I find algorithms that just remember this is just a guide. I think what's really important is that this is telling us that patients who are diagnosed clearly have pulmonary arterial hypertension, that patients should have vasoreactivity testing, and we don't have time to go through the definition of who's a calcium channel blocker responder. But if your pressure's normalized with any of our agents, whether it be nitric oxide or adenosine, then these patients are in a separate class. Every patient should have general measures throughout, which include oxygen if needed, diuretics, digoxin plus minus, and right now we are not recommending anticoagulation. And what this table is really trying to show is that patients that have risk, really, if they have lots of comorbidities, you just want to understand if the comorbidities are the predominant problem or if it's the pulmonary vascular disease. And I was just at a meeting where we were debating this extra step. And I think what's important for everybody on the call is really that if these patients are intermediate or high risk, we're recommending dual oral therapies. If you're a high risk, irrespective of your comorbidities, we're really trying to be aggressive with that. And they're recommending sort of upfront triple therapy with prostacyclin based on a very small cohort from France. I think that Aaron and I we can all have different choices of what we want to utilize. Some of it is up to us. Some of it is up to their insurance. Some of it is up to the patients. And sometimes patients just don't tolerate the therapies that we think they're going to tolerate. But I think we're all in agreement that we want to tackle this disease like it's a cancer and give patients the best available options, and to try to treat them quickly with therapeutics and not wait to see how well they respond for months on end. We used to wait 6 months. Now it's more like 4 to 6 weeks. If you don't see any difference, then we're going to escalate. Based on the AMBITION study, we no longer recommend just starting one therapy and adding. We recommend dual therapy upfront. Whether that's an ERA plus PDE5 versus an ERA plus a guanylate cyclase stimulator. I don't think we have enough data, but I do think we have a lot of data on the ERA PDE5, and that's why this has become part of the classification. I'm just trying to get the whole thing in. And then, what's really important is just continued follow-up, because if you don't see them often enough, you're going to miss them, and you're not going to see if they respond. And so if at any time they become low risk, then you're maintaining therapy and you're still following them closely. And then over years that can sort of slow down. But if they progress, then, these are the patients, if they're high risk and they're not responsive to therapeutics, then they really should be evaluated for lung transplantation. So before I move on, Erin, is there anything that you wanted to add to that? Because it's a lot. I didn't see if there were any questions about it. And I think that the one thing that I think is good about these guidelines is that they're not as prescriptive as they could be. Sometimes it's not necessarily how we're doing this in clinical practice, but I do think the one thing that is consistent is starting dual therapy and being aggressive if they're high risk. What do you think?
No, I totally agree. I think, and I would stress a couple things. One, as you already did, that this is a hemodynamic definition, so a good, solid, clean, clear right heart catheterization with vasodilator testing is critical to making treatment decisions. And these are complex therapies, so early referral to a center is always recommended. And there's no question that there's tremendous benefit in combination therapy. And I think that often is limited somewhat by insurance and the cost of these meds, but I think we need to really push aggressive treatment because we've seen really impressive responses to that approach.
Yeah, and to realize that we don't know how long response will be. And that's why the referral to the center ends up being more important than anything else. And that's because we have the resources to do all these prior auths and to contact these patients. And they're high maintenance patients because they're not well. And even when they're low risk, it just takes a little bit to push them over the edge. And so in these guidelines and in all of the guidelines over the last decade, it's really to try to get it to us a little sooner. So that's my statement for tonight, which is if you have a patient that has pulmonary hypertension, you really want folks that are experienced with it and have available, even clinical trials, because what you're going to see now is a whole bunch of clinical targets that are possible for clinical trials. And we have no idea yet which ones are going to be best or which ones to target, but there's definitely a lot of potential new therapeutics coming out. So this is one that shows the regulation of BMPR2 signaling. There's a compound that's already in phase 3, which we will get to shortly. You can inhibit Rho kinase. Most of the folks on this call probably are clearly familiar with statins and Fosdil. And so, we've seen all of our animal models. I think Sebastian Bonnet said 50% of the time will work. So it doesn't always translate to humans, but we're trying to figure out which targets we should actually go after. And then you have tyrosine kinase inhibition and platelet-derived growth factor. You have epigenetic and DNA damage. Because, what's the point of getting rid of the negative, like all the fibrosis and the cells that are senescent if we're not actually getting them out of the cell? And so how do we fix that? Smooth muscle proliferation, we are still trying to target. Then we move to metabolic and ion channels. There's stuff we've shown in heart failure that iron repletion is important. Is that important in pulmonary vascular disease? Reducing oxidative stress. We want more aerobic and less anaerobic metabolism, inflammation, anti-inflammatory drugs. I think we still, okay. So I thought the list was going to go on, but you could have an entire talk on just pick 5 pathways and go through it and show the evidence. And so what I'm trying to say with this is that there's a lot of potential. And again, this is a disease that used to be fatal, and we now have a lot of options. So I think it's always good to have a case. So this is a 25-year-old female to try to put it all together. She recently relocated from Atlanta. She presented with syncope and dyspnea, and they did a right heart cath there and diagnosed her with PAH. She was started on dual therapy, ambrisentan and sildenafil. Now we often use ambrisentan and tadalafil because they're both once a day, but equal efficacy, and reported, quote, doing okay. And that's part of the issue with young patients. They always say they're doing okay when they might not actually be doing okay. And you really need some kind of objective measure. So with her history, she had exertional dyspnea, climbing stairs, hills and inclines, which is not normal for a 25-year-old. When she has to carry anything, especially upstairs, she gets dyspnea and pre-syncopal. She's functional class 3 in our functional class system, which is intermediate to high. She's able to do things, but she is quite limited. She doesn't have any cough or any kind of respiratory symptoms or pleuritic pain. She didn't have any chest pain. And she didn't have signs of left heart failure, which is orthopnea and paroxysmal nocturnal dyspnea, but she did have some lower extremity edema. And she was sleeping pretty well. She denied symptoms that would be consistent with sleep apnea. Her other history, she doesn't have any family history or any signs or symptoms of connective tissue disease, no Raynaud's, no liver disease, no thromboembolic disease. She reported that she didn't tolerate prostacyclin therapy. She has an IUD in place, which is important because we don't want these patients to get pregnant. Because it's a risk for the mom and the fetus. And she has endometriosis and had an abnormal PAP. So her assessments, she did a submaximal exercise testing, which I think was a 6-minute walk test, and she did pretty well. And that's pretty common. I think with patients that are young, they're able to walk flat quite well. And realizing that that's not getting them to an anaerobic threshold. And the breathing efficiency was within normal limits. I think that you were doing CPET on this, correct me?
Yeah, this is actually one of my patients. The submaximal test was actually a step
Right.
test with gas exchange.
Okay.
So we get a VO2, end-tidal CO2, and oxygen uptake efficiency. So along with that, you get the VEVCO2, or breathing efficiency. So it's a very nice test.
Yes. So then it's better than a 6-minute walk test because we're getting some physiologic data, but yet not doing the formal CPET, correct?
Yes.
Okay.
Yeah.
But the indices of the pulmonary blood flow was reduced. So there clearly was vasculopathy with this. And her echo, which as the cardiologist, it's not subtle. You can see the right ventricle is extremely dilated, although it's not moving. You can see that the LV is underfilled. And I can tell you that it's normal function because if it wasn't, then the patient would not be able to walk around. The right atrial size is markedly enlarged. And again, you have underfilling of the left atrium. And, these are patients that when you look at this echo, you just say, wow, I don't know what she's complaining about because she should be complaining about a lot more based on this echo. But it also shows us that patients can acclimate to this. And you can see that there's right ventricular hypertrophy as well. So the right ventricle has adapted some. Her exam was consistent with, these are things that you can look for, which we went over before. So I don't think we should spend time on. And then all her review system is negative. Eyes, ears, respiratory, cardiovascular, GI, constitutional, endocrine, musculoskeletal, allergies, neurologic, hematologic. She was well. She essentially had, I'm going to get to the positive parts. She didn't have elevated neck veins, so we were looking for signs of right atrial enlargement. Her thyroid was not enlarged. She had a normal S1, S2, and she had a 1 out of 6 to a 2 out of 6 holosystolic murmurs heard along the left parasternal border, non-radiating with a loud pulmonic component to the second heart sound. She had clear lungs without any dyspnea. Her abdomen was benign, and her extremities neurologic intact, skin warm and dry. And you can see her vitals. She was 134/86, a little bit high. She was oxygenating well. She was not obese. Her pulse was 92, and her preliminary connective tissue disease laboratory were all unremarkable. And so then that gets us to the next poll question, which is, what further tests would you order for this patient? Now, arguably, and we're going to say this up front, that all of these tests can be ordered, and there's never one perfect test because we know she has PAH. But I'm going to give you the choices: chest X-ray and pulmonary function tests. Like, has she now developed lung disease? A VQ scan? Does she have clots? Or an MRI to better assess the RV? Although we can see that the RV is quite enlarged. Maybe we missed congenital heart disease. A repeat right heart cath. CPET. So more exercise physiology and hemodynamics, or I don't know. I do think it's important to point out that a CTA is not how we want to rule out chronic thromboembolic disease. That, in all of our guidelines is a VQ scan. Unfortunately, at GW, I don't think we're still doing the ventilation portion because of COVID, which is driving me a little crazy.
Although I will say, with newer technology, dual energy CT and some others, VQ,
hopefully we'll get it out.
Art that will be relegated to the back closet. So
Results are in? Okay.
Our results are in, and to be honest with everyone, this is not at all a fair question, because a lot of it depends on how she presents. There's no question a right heart cath is always helpful when someone doesn't appear to be doing as well. And I will tell you, though, in this case, we actually did an invasive cardiopulmonary exercise test because we were looking to put her in a clinical trial.
So you know what, Aaron, I will add that sometimes when you inherit a case before, the patients don't always have all the records, and you don't have all of the testing. And I definitely inherited patients that were thought to be idiopathic, which when they had their VQ scan for a clinical trial was found to be chronic thromboembolic, or you missed an ASD because you didn't see it on the echo, but you can see it on the MRI. So, I do think it's always worthwhile to be thorough with a new patient just to make sure that you have the right diagnosis.
Absolutely. I mean, when she actually transferred her care up to Boston, we did a right heart cath, and typically with our right heart caths, we also do limited selective angiography just to make sure we're not missing anything when we're in the cath lab. And her vessels, although showed lots of pruning, were clean from the standpoint of thromboembolic disease. And I'd also point out with her that the reason she was on dual combination therapy and not triple therapy, because again, she's young, she's got bad disease, and was not really, even though she said she was okay, that really meant she was still quite limited. She could never tolerate a prostacyclin, and we really didn't have any other options. So that kind of brings up this next idea of doing an invasive cardiopulmonary exercise test and hemodynamics. So basically, we had talked to her about going into a clinical trial. And this invasive CPET is not something we do routinely on our pulmonary hypertension patients, although it is a tool that we use clinically for evaluating patients with unexplained exertional intolerance in the hopes of finding very early pulmonary vascular disease. But in this case, it was used as an entry criteria for a clinical trial. And what you're seeing here are the baseline numbers when she before she started treatment, but entered the clinical trial. And I think the key features of this are that, one, she was only able to exercise for about 4.5 to 5 minutes. And you can see the mean pulmonary artery pressure there at rest. And this is in the upright position. So she's sitting up on a bike with a right heart cath and a radial arterial line, so that these are true Fick principle readouts and true cardiac output assessments that give us the pulmonary vascular resistance. And so you can see the pulmonary vascular resistance is quite high at 497, and normal when this was done should have been no higher than 240 dynes. Today, a normal PVR at rest should be about 160 dynes. But the bottom line is, you can see there's still very significant pulmonary hypertension here, in spite of her being on what should be effective therapy. So, based on this data, which again was not something you would routinely obtain, but a question is, what treatment strategy would you recommend next for this patient? And I think I gave the answer away, but you can still voice your opinion.
Well, I think reassessing in 12 months is definitively cannot be the right answer.
That's
If you said 6 months, then, it's still not the right answer.
Yeah, no, she's already declared herself as having trouble, so she needs something now. The idea of Rio-Sigwat, there is data as far as switching patients within classes and within pathways.
Great.
That people can benefit. So that is something one could consider.
But you add on to it, I think, is one of the key, because you don't use a PD5 with. Yeah,
you'd have to switch her.
Yeah.
And sildenafil does come in an IV formulation, but it's only really intended when people can't take PO in the ICU. It's the same dosing. Well, it's a 10 milligrams IV as opposed to 20 PO, but it's the same effective dose. And we would not put a patient on IV sildenafil in the outpatient realm. So really the best option is a clinical trial in this case. All right. So treatment options, I think we've made it clear. We offered her entry into a clinical trial with sotatercept, and I'll explain what sotatercept is, but there were a number of clinical trials going on for sotatercept at the time. Both were phase 2. There was a large phase 2 study that was kind of a traditional placebo-controlled trial, but at our institution and at the University of Arizona, we also performed an open label study where patients came in, they did an invasive cardiopulmonary exercise test at baseline, and then went into the study and guaranteed to go on drug. So let me first start out with what is sotatercept. And I think fundamentally when we think about pulmonary hypertension, a lot of focus is on the bone morphogenetic pathway. And the bone morphogenetic pathway, the fundamentals are the BMPR2 receptor that activates that pathway, and that pathway works through a series of proteins, the SMAD proteins, and specifically the 158 pathway. And when this pathway is activated, or actually, dysregulated, it drives the remodeling that we see in the pulmonary blood vessels. And that remodeling is characterized by pro-proliferative, really almost a neoplastic process, such that these pro-proliferative mediators outperform any anti-proliferative signaling pathways. So it becomes an imbalance. And as you downregulate the BMPR2 signaling pathway and downregulate the SMAD 158 proteins, what we start to see is this increased activin ligands. And these are growth differentiating factors in activin that bind components of the TGF-beta system and drive this pro-proliferative balance or imbalance. And this tends to cycle itself so that as you activate the activin pathway, you turn on SMAD2/3 rather than the other ones that we talked about. This drives up the amount of additional proteins, gremlin-1 and noggin, which then go back and inhibit the BMP pathway further. And the idea was, and a lot of this is based on animal studies, that if you could reduce those anti-proliferative signaling and shift the balance back to less proliferation and really control all that excess proliferation, then you could potentially drive reverse remodeling of the pulmonary vascular bed. So the way sotatercept works is it's a ligand trap. It's a fusion molecule with the Fc domain of a human immunoglobulin G1. And this molecule essentially traps these ligands, activins, and growth differentiating factors so that they can't bind the BMPR receptor. And it has the effect of, by really grabbing all of this stuff, not letting it activate the pathway, rebalancing that pathway so that there's a more normal balance between anti-proliferative signaling and pro-proliferative signaling. And the animal studies that were done that led up to this clinical trial actually showed pretty impressive remodeling of vascular beds in a number of animal models of pulmonary hypertension. But as Marty pointed out, you never know until you take it to the human, because we have cured pulmonary hypertension in lots of mice, but not yet in humans. So this led to the clinical trial. And in the trial that was ongoing while we were putting these patients into the open label trial, as I said, was a placebo-controlled trial called Pulsar. And this was actually published in the New England Journal last year. We enrolled patients in a 1-to-1 fashion, so that there were 2 different doses that we studied. And you can see here about 32 patients went into the placebo arm, 32 into a 0.3 milligram per kilogram. And this drug is injected subcutaneously once a month. Every 21 days, and then a second dose of 0.7 milligram per kilogram, and 42 patients went in there. And I think importantly, you can see that the patients were nicely divided by WHO functional class 2 and 3, so intermediate to high risk patients. Patients were on background therapy. They all had to be on at least 1, if not 2, if not 3 drugs that are already approved for pulmonary hypertension. And a good number of these patients were on triple therapy, but still remained functional class 2s and 3s. And you can see their hemodynamics down at the bottom, the pulmonary vascular resistance. Again, a normal pulmonary vascular resistance at this time was considered to be 240 dynes. So these are quite significantly elevated. And there's the 6-minute walk distances, and then the NT-proBNPs, all of which for the average age of these patients were impaired.
And I think it's also important to point out that a lot of these were on really max with parenteral prostacyclin. Many studies before this have not included these patients, but they actually, which you're going to show, actually did well with the agent. But it's showing that these were patients that had been really truly treated with maximum therapy, and yet we're trying to see if there's a benefit to the drug.
Right. Okay. So this shows you the data from both the placebo arm and the patients who were on sotatercept, who went into the long-term trial, open label extension as well. And what we saw in this was a significant improvement in pulmonary vascular resistance, so that the pulmonary vascular resistance came down significantly. We also saw a significant improvement in 6-minute walk distance, which you can see in the center panel there. And then in the third panel, we saw significant decreases in the NT-proBNP, all consistent with improved right ventricular function and improved pulmonary hemodynamics. And I think really importantly with this, and something that we often don't see in clinical trials in this disease, is that the placebo patients actually caught up to the patients who were on drug the entire time, which is quite remarkable, especially, again, when you consider that all these patients were on significant background therapy. This shows you the changes in WHO functional class as patients transited through the study. And essentially, we saw a very significant improvement in patients moving up at least one functional class or down one functional class from when they entered the study until they finished the 6-month placebo-controlled arm, and then again as they entered the extension phase. And again, patients who were on placebo caught up to those patients who were on active drug throughout the study. As far as dose modifications, I think from a treatment-related adverse event, probably the most important adverse event we saw was a rise in hemoglobin. There were very few patients who actually had to discontinue the study because of that. And very rarely did patients require any sort of phlebotomy, but phlebotomy was indicated based on the protocol, not necessarily because the clinicians felt it indicated. But you can see here that it was pretty well tolerated overall. And now moving to some additional treatment options. So as I said, our patient entered into this open label study where we did invasive cardiopulmonary exercise testing at baseline, at 6 months, and then at 12 months. And the idea of this clinical trial was to get as much physiologic readout as we could in the hopes of defining how much remodeling was happening in the pulmonary vasculature and in the right heart. These patients also had cardiac MRs, echoes, and a host of other testing. And we're still analyzing the data, but I can show you some of her data. And she, at the initial month after starting treatment, she actually started feeling better. And I can tell you, most of our patients started feeling better within 2 to 3 months. And she actually felt good enough at this point where she actually started going to the gym and joined a gym and has been working out ever since. She's been walking more. She's actually gone back to work, and she just finds she can do so much more without the same effort that she had before. And review of systems really was pretty unremarkable. Really, all of her cardiac and pulmonary review of systems were pretty much unremarkable. And within a couple months of her starting, and I can tell you that this has been a persistent assessment, is that she is now a WHO functional class 1. Which really is the goal of therapy. So to take you back to her first invasive cardiopulmonary exercise test, this is it. And then we'll look at the one that she did 6 months later. And now what you can see in the very first column, the time of exercise, remember before she did about 4.5 minutes. Now she's doing almost 10 minutes of exercise on a ramp protocol on an upright bike. You can see in her mean pulmonary artery pressure is actually low when she starts and never goes into a pathologic range. Generally, for us to call it abnormal with exercise in a normal individual, they would have to get a mean pulmonary artery pressure up over 30 millimeters of mercury, which she never does. You can see her right atrial pressure and pulmonary capillary wedge pressure also quite low. And I think that's an important thing to take into consideration because the pulmonary vascular resistance is still on the high side. And I'm sure she still, at this time, at 6 months, still has some stiffness in her vessels, but so much marked improvement compared to her baseline. But also PVR is affected by these low pressures in her wedge as well. So I think the bottom line is we see remarkable improvement in her hemodynamics and her exercise tolerance. So Again, I just want to stress that we did not offer triple therapy only because she couldn't tolerate prostacyclin. She had tried several different approaches to prostacyclin therapy, and all of them just made her feel horrible. So let me touch on a couple of study-related things that are going on out there. I think Marty had mentioned the idea of triple combination therapy out of the French group in Paris. And I think they have done a number of studies that demonstrate very nicely that when you're very aggressive with therapy and approach this disease as if it were a cancer, starting 3 drugs all within a very short time period, the results are very good, and patients show significant improvement in hemodynamics and quality of life as well as functional class. So again, I think it's important to use what we have out there while we wait for these clinical trials to finish. So now what I'm going to do is just touch on some of the other clinical trials that are ongoing out there, because there's a lot happening that I think will change the way we practice in the next couple of years.
Yeah.
So this first study is a phase 2 trial that is ongoing and still enrolling. It is looking at rodatrostat ethyl, which is a prodrug of a peripheral inhibitor of tryptophan hydroxylase, which has the effect of inhibiting the rate-limiting enzyme in the production of serotonin. And serotonin has been implicated in pulmonary vascular remodeling really for many years. It's just a matter of finding a drug that actually patients can tolerate and is effective. And so this drug is tolerated, and now we're trying to find out if it is effective. As I said, there's a phase 2b trial. Patients have to be on standard of care drugs in the background, and it can be 1 to 3 drugs. They are randomized in a 1-to-1-to-1 fashion as far as 2 doses of drug and versus placebo. The study will go on for 24 weeks, and that's important, especially when we're trying to see if there is evidence of vascular remodeling, because that does take time. But there will be an interim analysis at 12 weeks to find out, 1, is the drug safe, and is there any early signs of efficacy? So this is about halfway enrolled at this point. The primary endpoint is pulmonary vascular resistance, which is not uncommon in a phase 2 trial. And then there are a number of secondary endpoints that include the rest of the hemodynamic profile, time to clinical worsening, 6-minute walk distance, and functional class, to name the few. This is a study called Advanced Outcomes, and it's looking at ralinepag. Ralinepag is a oral non-prostanoid selective potent IP agonist, and IP is one of the primary prostanoid or prostacyclin receptors. It's a similar drug to selexipag, but it's a much longer acting drug. So it's really trying to figure out if this drug is as effective, and especially in combination with other drugs. This is a phase 3 trial, and the primary outcome is time to clinical worsening. And this is currently enrolling patients. It's a little further along than the serotonin study that I mentioned. And then this study, which I think is of importance because this is seralutinib, which is a platelet a PDGF inhibitor, which is similar to imatinib. And imatinib had significant efficacy, but also had a significant safety problem. This drug is a more focused PDGF inhibitor, and it is delivered as an inhaled PDGF inhibitor. And PDGF has significant role in vascular remodeling. It also has crosstalk with the BMPR2 system. So it's a nice target because it is a pro-proliferative pathway. It's also a pro-fibrotic pathway. So it may have important role in treating pulmonary hypertension, as well as pulmonary hypertension in the setting of lung disease. And this is just starting as a phase 2 study. and it's looking right now just at group 1 pulmonary hypertension, including idiopathic, heritable, and connective tissue disease, as well as drug and toxin related. They are also enrolling repaired congenital heart disease. The primary outcome in this is a 6-minute walk distance in functional class, and patients can be on background therapy. So that's just a small flavor of some of the clinical trials that I think are likely to be quite important as we move forward. So kind of finishing up here, I think importantly, and I hope we've gotten the point across, that thinking about the right therapeutic strategy is key to getting our patients doing better and living longer. And it really requires us looking at a patient's risk factors, their preferences, and their support systems, because these can be complicated therapies. We also have to take into account any comorbidities as well as concomitant medications. And there's no question all these meds have some degree of side effect, and balancing those side effects with efficacy is important, especially when we start to combine these drugs together. But I would stress that combination therapy can oftentimes allow us to use lower doses of drugs and get the additive or even synergistic effects of combining those drugs.
So before we conclude, because I think that the conclusions are we have an unmet need, and there's more that we can do, just because I do want to get to some of these questions. So the first one, I think, Aaron, that was a fantastic overview, and we never have enough time to talk about pulmonary hypertension. I just remember that we used to have a hard time filling the 55 minutes. Now we could have individual talks that could last a day. The first one is a CPET question. So it's if a PAH patient has an obstructive defect and is an unresponsive heart rate on a CPET result, is the patient having further progression of PAH? Like, what does that mean?
So obstructive defect, I'm going to assume you mean a pulmonary obstructive defect?
Yeah, so I was going to say, I think, first I wasn't sure if they were talking about an obstructive defect, meaning heart disease, but I actually think it's a pulmonary function obstructive defect.
So, and if we're talking a non-invasive cardiopulmonary exercise test, there's no question that when you combine PAH and obstructive lung disease, or restrictive lung disease for that matter, it's going to worsen some of the parameters. Obviously, the VE/VCO2 slope will be affected by both disease states. But I think importantly, CPET can be helpful if you want to track how a patient is responding. None of that matters with invasive CPET, because you have hemodynamics that will then allow you to figure out what's their primary, secondary, and tertiary limits to exercise. With non-invasive, though, I would suggest that CPET is helpful to guide you as to the patient's response. It just gives you a lot more information than a 6-minute walk does. So if I see the VE/VCO2 slope or the breathing efficiency rising, it tells me the patient's doing worse from a PAH standpoint, because the likelihood is the obstructive defect can be treated well and is going to be stable as long as that patient's no longer smoking or their asthma is well controlled. Hopefully I gave you a good answer for that.
Yes. So the next question, first they said this was a great talk, which is always nice to hear. Is there a connection between PAH and endometriosis in terms of the pathophysiology of the vasculopathy? And I think that's a really interesting question. I was fortunate enough to be a co-author on a paper really describing pulmonary vascular disease as a systemic disease, and that there's just a lot we don't know, and the overlap between the endothelium everywhere, to be honest with you. And so we haven't looked at it, but I would bet that there are some similarities. I think what's important in these patients is that when they get significant menstrual cycles and with significant bleeding and pain, that actually does affect their pH and how they're feeling. And anemia is not a good thing. So treatment of their concomitant disease is really important. But I don't think there's been any look to see if the pathology and the vasculopathy is similar.
No, and endometriosis can affect the lung and the pleura. And there are these conditions such as catamenal pneumothoraces and catamenal hemoptysis, where patients with endometriosis in the lung can actually have coughing up blood or even pneumothoraces. So, but I'm not aware of any association because, one, it's a different tissue. I think the hard part is when a woman has endometriosis and the role of hormonal therapy in a patient that we're worried about being a thromboembolism, that complicates the whole picture. But that's probably a whole other discussion.
Yeah, and anytime they go for any kind of surgical treatment for anything, the PAH patient's at a higher risk. So it's just not good to have concomitant disease. And then the second part of the question was, is there a dose weight cutoff for sotatercept? So if you have a BMI of 50, were you able to be in the trial?
I can tell you we didn't have any patients that big in the trial. I think there was a cutoff for the trial. There is not. We are not putting anything in as far as the application to the FDA as far as a cutoff. It is a weight-based dosing, so it may be a little uncomfortable with the injection for someone who's morbidly obese, but it shouldn't be an issue.
I actually think that the issue is going to become how many shots you're going to need based on how they've formulated it, instead of just having one shot based on how it's reconstituted. And so I think eventually there will not be necessarily a weight limit, but right now we have not put folks with high BMI into the trial. And then this is I think both of us can answer, which is, what are factors that you discuss with your patients with PAH when deciding initial therapy or whether to enroll in a clinical trial? Now, it's always easier when you've met the patient or you have some sort of rapport with them. When you meet them in the hospital, I think that's really hard because sometimes folks really need aggressive therapy and you have no concept if they can handle it from a psychosocial, socioeconomic standpoint. So I think you want to educate the patients as much as possible. For me, I'm always happy with whatever they choose, as long as they choose something. And you want them to feel comfortable with the therapeutics. And sometimes even showing them, because I think that there's been a lot of folks not being started on continuous infusion because of the fear and because we have other options. But I think if you sort of desensitize them to it and introduce them to it, if that's really what they need, then it takes some coaching and relationship. But for me, any of the dual is fine. And usually I try to start with once a day to make it easier for the patients. But again, sometimes the patients just don't tolerate medication, like your patient who didn't tolerate prostacyclin at all.
Yeah, for our program, we have a pretty large program with a large number of providers. We have 8 physicians and 4 PAs and a host of research coordinators that all spend time with the patients as we meet them and get to know them. When it comes to advanced therapies like prostacyclins, we actually also engage the home care companies and do a lot of teaching before the patient can make their decision so that they know what they're getting into and generally understand it well enough to make an informed decision. Because we do believe still prostacyclins are the best drugs we have for those patients with advanced disease. And to me, that's anyone with a functional class 3 or 4. So we like the drug, but it is a complex drug and it's not for everyone. So we may recommend it, but ultimately it is the patient's decision. And obviously it is easy to give pills, especially once a day, but unfortunately insurance doesn't always agree with that. So
and inhaled as well, right? So
no, I actually use a lot more inhaled than I ever thought I would. And I think it's a great way to do it, but that's 4 times a day. Which can be difficult, although with the new dry powder inhalers, it makes life much easier.
Yeah. I would say that I've been pleasantly surprised in folks that don't have family support or another person as a backup, or just don't have the means, or their environment isn't clean enough for a continuous infusion. I've always been in big cities, and so sometimes it's just not an option. And I've seen great results with triple therapy that hasn't been IV. So I think it's really the patient and the entire circumstance. There was at one point we had a psychologist talking to patients to see if they were going to be able to handle these therapies. I think we need to do more of that because it is a lifelong therapies that they're going on. And I think that we often forget that it's a big change in their lifestyle. But
we've also engaged patients to talk to patients. A lot of our patients are more than happy to speak with them on the phone and tell them what they went through as they start to feel better.
All right, Aaron, I guess you can do your concluding.
So I think we've stressed already that PAH is a devastating disease and a progressive disease. There are some, I would say, effective therapies. There's still lots of room for more. And as we are now in the realm of combination therapy, I think, one, the treatment becomes more complex, but also far more effective. But I think as we move forward with these clinical trials, we're really entering a whole new realm of treatment that will be targeting remodeling rather than just vasodilation. So stay tuned. And I guess, are there any other questions?
Oh.
Okay. And I think that is the end.
Thank you all for joining us, for sure.